Super excited to have Spencer here joining us today. So I'll hand it over to you, and yeah, looking forward to the next 45 minutes or so.
Thanks, buddy. All right. So this is a topic near and dear to my heart, obviously, because I do a lot of GLP-1s, and I'll tell you a little bit more about my history with them. But as I'll go into it, I do think there's been a lot of pushback by personal trainers and fitness professionals in the past, but I actually think embracing them is the right move, and I'll get into why. So, and I do a lot of these teachings. I've done a lot of obesity training to fitness professionals in the past, and I think you all are very smart and equipped to help a lot of people who struggle with their weight move and improve. All right, so quickly, who am I? I kind of coined the term, does your doctor even lift? In fact, I trademarked it for a while. I think the trademark died. I didn't update it, but have a podcast called Docs Who Lift. Really passionate. I wrestled in college, university, if you're abroad, and you call it that as opposed to college, but wrestled heavyweight, played football, Division I, really big proponent of lifting weights as medicine. And I've developed a few online clinics in the past. One of them got bought by Weight Watchers, and I'm just developed a new one that's really focused on body composition, but obesity, losing weight, that people need to lift weight. So you guys are very important. So that's just a quick about me. Obesity specialist, also a lipidologist, which is like the study of cholesterol and lipids. So I don't want to belabor about myself. We're going to get into just kind of an intro of GLP-1, glucagon-like peptide 1. We're going to go into some of each of these things. Review the medicines, so our own endogenous natural GLP-1 versus the medicines, why that matters, the impact on you all as fitness professionals, then some ethical considerations, and then communication, which I think is the most important part, to help you guys get more clients and then help your clients better. And then we'll do a little bit of a Q&A. And of course, if you have questions in between, this is pretty laid back, so feel free to ask questions, and I'll kind of keep my eye on the chat. So a quick introduction to GLP-1. I love this topic because glucagon-like peptide 1. It turned out that like in the 50s or 60s, they did this experiment, and they had people inject glucose into the veins. And so that glucose, goes right through your bloodstream, right to your pancreas, and tells your pancreas to start making insulin. The insulin helps get the blood sugar into the cells. They also compared drinking glucose. Now, I would think that if you injected glucose straight into your veins, you would see a bigger insulin response and a more of an effect. But what they found out is that drinking the glucose caused more of an insulin response. They call it the incretin effect. It's intestinal, and intestines and secretin was another hormone that they were looking into. So they just kind of combined it all and called it incretin. So the incretin effect back in the 50s or so, when they figured this out, was exactly this. Now, GLP-1 was actually discovered in the 80s and is one of a few different incretins. But that's kind of that's the natural GLP-1. Now, I keep seeing these videos about people, drink some olive oil, eat some blueberries. It's basically better than Ozempic, which is, I'll get into what that is, but one of the GLP-1 receptor agonists. The issue is our own endogenous, our own natural GLP-1, our own natural glucagon-like peptide 1, which comes from the small intestines. We eat food, gets into our small intestines. There's these little cells called the L cells. They release this GLP-1. It gets broken down very quickly, like within a minute or two, by this enzyme DPP4, dipeptidyl peptidase 4. Anyway, it gets broken down very quickly. Now, it has the effect enough to help our pancreas make more insulin, does a few other things, obviously. But we even have drugs that block this breaking down called DPP4 enzyme inhibitors, and it can increase our own endogenous GLP-1 by 2 to 3 times. And we don't have any weight loss from it. It's very neutral in terms of weight loss. The blood sugars do improve. So just something for you all out there watching these videos of these. I see so many videos and I have to make a response, and they just keep popping up. But if you see anybody selling supplements, selling some sort of food combination to improve our own GLP-1 production to help it basically be like Ozempic, which again I'll get into, it's malarkey, it's nonsense, it's fiction, because of this effect. We break it down so quickly. It just doesn't matter. Now, what did they do with these GLP-1 receptor agonists? They basically modified human GLP-1. There's a whole history, and I'll get into that at some point, maybe in another presentation. But scientists were really smart. They took our own GLP-1 and they modified it in a way to where it basically doesn't get broken down by that DPP4 enzyme. And so that way, and over the years, by the way, it's gotten better and better. And initially it was like you had to inject it twice a day. Then it was once a day, then it was once a week. And now they've even modified it to where it has hits different receptors in the body. But now it doesn't get broken down by our body, hits the receptors differently in our brains, and has a much longer half-life, and you can increase it to levels that have just these major effects. So that's the difference between our own endogenous or natural GLP-1 versus these GLP-1 receptor agonists. It's kind of cool. I think it's really cool, actually, but it's a big myth out there that I want you all to understand so that you all can start kind of myth busting out there if anybody starts making these claims. So there were a bunch of different GLP-1 receptor agonists. There was one called Byetta or exenatide, that was 2005. Then there was one called liraglutide, that was 2007 or 2008, 2009, whatever. That was a once-a-day injection. It wasn't till 2016, 17 where Ozempic came out. That's semaglutide. That was for type 2 diabetes. But this, what I'm showing you right here, was the big kind of the game changer. Those were the headlines, literally game changer. And I'll get into why it's a game changer. But this one is Wegovy. It's the same stuff as Ozempic, but it was in a higher dose. So this was the game changer. Let me show you why this was a game changer. Here's the study. It's called the Step 1 trial. This was, you can see, February of 2021. This is when people were like, whoa, what's going on here? Even though Ozempic was around in 2016, 2017, so people really weren't talking about it. We knew internally, like, oh, we can give this off label to help people lose weight, even though it was only approved for type 2 diabetes. This is like the big one that came out. If you can see here, the placebo, these people were getting injections, by the way, but it was a placebo injection. They lost about 2% of their weight. And you can see here with the semaglutide injections, they got down to like, 15 or so % total body weight loss. Now, the reason it was a game changer is because when we look at lifestyle modification in randomized trials, gold standard randomized trials where they're doing intensive dietary and exercise counseling one-on-one, we see on average around 5 or 6% total body weight loss over the course of the year. So we're talking right around here, right under that placebo. Individuals will vary. I mean, you all probably have some major success stories. You have some people probably that lost like half their body weight and things like that, but this is just on average. So when you look at this semaglutide group getting 15 or so, that's like 3 times what you'd see with lifestyle alone. Now, this was also a game changer because we didn't have any other drugs that did anything like this. There was another drug that got 7 or 8%, around 10%, which is decent, but there were side effects to those. And bariatric surgery is around 30%. So now we kind of have this something that kind of bridges this gap between lifestyle and bariatric surgery. It was a really big deal, and it still is. Obviously, we're seeing everything about it. Allie asks, will you get into the difference between Wegovy versus Ozempic? Yeah. So Ozempic is just, these is a branded thing. This is what these big official organizations do, the FDA and in Europe. They have to brand things a certain way for indications. And it's also partly marketing. It's a little bit of a big pharma ploy, honestly. So Ozempic started and only went up to 1 milligram of semaglutide at the time for type 2 diabetes. Wegovy goes up to 2.4 milligrams. Now Ozempic does go up to 2 milligrams, but again, if you're trying to get insurance to pay for it, insurance will only pay for Ozempic if you have type 2 diabetes. And then only like a third of the time, really, they'll pay for one of these medicines for weight management, this one being Wegovy. Let's see. Yeah, I'll get into some of these a few of these other questions in a second. Here's another cool graph of looking at, this is called categorical weight loss. And when you look at just like placebo, basically lifestyle by itself, you can see like 30% or so lost 5% of their weight. And then look at, I mean, a few people lost 20% of their weight. That's pretty good. But when you look at like people who are taking the Wegovy, the semaglutide, you can see half of the people lost 15%, a third of the people lost 20%. So this is just another way of looking at it. And to make things even more interesting, a little bit more than a year later, tirzepatide came out. Now, technically, this is what's called a GLP-1/GIP co-receptor agonist. So it's not just GLP-1 alone. They modified the peptide to hit two different receptors. They didn't just add them together and just say, all right, we got two different receptor agonists in there. This the molecule, the peptide, that can actually hit the different receptors. And this one actually gets around over 20% at the higher doses, by the way, 20%. So now we're even added another 25 to 30% on top of what the semaglutide does. Powerful stuff. Kind of same thing. You see the same thing with the placebo, by the way. Kind of similar story. Now, this doesn't show the graph for intensive diet and exercise training. They've done those studies, and it gets more around that 5% or so that I was saying before. These were just the first studies that came out, so I'm showing these. But you can see the big difference. I'm going to show this categorical weight loss. Now, you can see even a more pronounced effect, 25% now. Still, you can see some of the placebo did lose over 25%, so it can happen. But look at these drugs. It's like almost 40% hit a quarter of their body weight off. Pretty powerful stuff. Okay, then the question here from Ridwan was, just curious, does this product only deal with issues regarding weight? So this is what these specific, so there's actually Mounjaro is the same as this Zepbound stuff, the tirzepatide, but that one's for type 2 diabetes. The Zepbound is the one made for weight management. Now, there are many more effects beyond weight. I'm not going to get into the heart attack stuff here, but it's likely, yeah, people lose weight on them, and people are like, oh yeah, of course, that's why they're reducing risks of heart attacks. But there's something about the GLP-1 receptor is actually responsible for reducing risks of heart attacks, not just the weight loss. Kind of interesting stuff there. And then Anne asks, I'm interested in hearing your opinion on those folks who are not obese or overweight, but use them because they want to drop a few pounds to look better, leaner. Good idea, bad idea. I'll get into that, and this is where you all will play a big role, but I don't recommend it simply because it hasn't been studied, and it can get into the same kind of idea of yo-yo dieting. So we all have people that want to look better in their bathing suit, look better for a wedding or whatever it is, and they'll crash diet or whatever for a month or so, and then regain their weight. And the worry is that if you use these just for a few extra pounds, you take it, come off of it, take it, come off of it, and you kind of keep cycling in your weight. It's hypothetical. We don't know what happens, but the potential harm is worsening someone's body composition over time, because they could lose some muscle. Then when they regain weight, are they regaining the same percentage of composition that they were before, or are they regaining more fat? Then they lose more muscle with some fat, then regaining, and is it mostly fat? So I don't recommend people using it for just small amounts of vanity weight. Having said that, it's probably for bodybuilders out there, they're like, well, it's probably safer than using clenbuterol and thyroid T3 and stuff like that. So, and they're probably right, but either way, I wouldn't at this time recommend people just using it for a few pounds to lose, unless they know they're going to be on it long term. or they think they can maintain. That's all. All right, I'll talk to you guys about a little bit more about the body composition changes here in a second. Yeah, I'll answer some of these more in just a moment. So people are like, well, how do these drugs work? Are they fat burners? No, these drugs work because there's receptors in the brain. It gets really complicated because there are certain receptors, say like down here, and maybe in the brain stem, maybe they hit receptors and then it has downstream effects further into the brain. Some of these GLP-1 receptor agonists may cross the blood-brain barrier. Anyway, no matter what, it doesn't matter. These drugs work in the brain to reduce appetite. And what I want you guys all to understand is that it's not just appetite like hunger and satiety. So like hunger, like, if it's been a long time, you're like, oh, my belly's rumbling. I really need to eat something, versus like satiety, after you eat a meal, you feel satiated. But then there's also like craving chocolate, whatever. I personally like salty, carby chips, like the tortilla chips with a little bit of hint of lime and things like that. Anyway, it reduces those. But then on top of that, in between, people talk about this idea of food noise. It's a relatively newer concept, but it's thoughts about food. So people aren't even necessarily craving anything specific. They're not even hungry. They feel satiated, but for some reason, they're thinking about their next meal, and they're thinking about the meal after that. They're thinking about how big it's going to be, what's going to be in it, and all these different things. And it doesn't have to be unhealthy foods per se, but something about these drugs dampens down the receptors that are involved with people just even thinking about food. And I think this is one of the big aspects of these drugs. Now, you'll see a lot of people online say like, hey, I was eating 1,200 calories and not losing weight. Mind you that, 300 pounds or something like that, 250 pounds. And now I went on this drug and now I'm eating 2,000 calories and now I'm losing weight. Physically impossible, didn't happen. Now I'll get into how to kind of speak to people about that, but that's just, it's literally physically impossible. These drugs help people eat fewer calories, which again, I'll talk about how it's going to help your all's life. It just makes life easier for your job. Not everything's perfect though. There are side effects, and I know, let's see, I could do a poll here, but it looks like we're getting still tons of questions. I don't want to do it, but most of the people, if you've seen patients or clients doing this, you've probably seen it to where they get a lot of nausea. Most common side effect, by far, it's the most common. Most people will feel a little bit of nausea, and there's some of this has to do with the gastric emptying, slowing of their stomach. That's a physiological effect of GLP-1. It slows how much your stomach is then emptying into your intestines. That, by the way, that can also increase the risk of reflux. If you have more in your stomach and it's not going into your intestines, it has more of a chance to kind of go up. So you do see some reflux with this medicine, but nausea is common. There's also receptors in the brain that are related to nausea that these drugs likely hit. And they're actually trying to refine these drugs to make them not hit those receptors as readily. Anyway, the tirzepatide, by the way, just a side note, compared to the semaglutide, that GIP component, that other incretin that they put, that they made the peptide hit the receptor of, that actually has antiemetic or anti-nausea properties about it. So it does seem to be better tolerated. But nausea is the most common. It goes away for most people. It's mild to moderate for most. You can minimize some of those side effects. This can start getting into medical nutrition therapy, and I can talk about it a little bit more. But kind of the common things that we tell patients, like kind of common sense. If you're trying to lose weight, probably not a good idea to go eat a big thing of burgers, wings, and chips, fries, and pizza and that type of stuff. Big, heavy, fatty meals are more likely to cause that nausea. So I don't think it's out of your scope to at least kind of mention like, hey, maybe it has something to do with your diet. And we'll get into more of your scope in a little bit. Constipation is one thing. It slows their GI tract a little bit. So you do see that. But physical activity, making sure people are drinking enough, eating higher fiber foods can minimize that, or at least reduce it a little bit. We do see diarrhea from time to time. and it usually resolves. A little bit out of your scope, but I use like Imodium and Pepto-Bismol to help with that. But over time, it resolves. I don't go up in the dose if they're having diarrhea. I do want you all to pay attention to fatigue. It's not talked enough about in the online space, but something about these medicines hit receptors in the brain that for some people, not everybody, a lot of people still feel a lot better, but some people feel more tired. And it's not necessarily like, some people feel like they want to go to sleep, but it may just kind of dampen them a little bit to decrease their motivation. But certainly something you all would probably know, especially if you're, working with somebody one-on-one, watching how they're doing and watching their reps and their volume of how much they're lifting and their motivation to go to the gym and all that type of stuff. I do think it's worth paying attention to. And we'll kind of get into some of that communication. Let's see. Are there any more questions? Oh, Allie, is Wegovy more effective due to the higher dosage? No. So the tirzepatide is more effective just simply because of the way it hits the receptors. And because of the GIP component, there may be something about it that helps downstream as well. It's hard to say. Let's see. All right. Okay, we're going to talk about where this muscle or where the weight loss comes from here in just a moment. Here are the scary side effects. This is a lot of stuff you'll see about the fear mongering, and you'll see. If you follow me on Instagram or whatever, I debunk this stuff all the time. I do it on my podcast. But pancreatic cancer, it was a concern in the beginning because, like, well, these drugs are working they have an effect directly on the pancreas. They're stabilizing the beta cells, which are the cells that are responsible for producing insulin, and maybe it's causing proliferation of these cells, and could that spur a cancer? They've looked at huge trials. Again, these have been out for almost 2 decades now. They combined all the data. Doesn't seem like there's a difference between the placebo arms and the drug arms, and even like post-surveillance marketing and observational trial studies, they don't seem to notice any signal there. Pancreatitis was the same kind of concern. Same thing. We do see pancreatitis from time to time, and it kind of gets interesting because you can get something called a gallstone pancreatitis. We do see gallstones from people losing weight so quickly. If they're losing more than like 1% of their body weight, so if let's say they're 300 pounds, if they're losing on average more than 3 pounds a week, it can put them at risk for developing gallstones. That gallstone can then go down the duct and get and block the pancreas secretions. So then it can cause a pancreatitis. We do see it from time to time, but even when you put all the data together, it doesn't seem to be statistically different from the placebo. Thyroid cancer is another big one. You'll see there's a big black box warning on the drugs. It's like, these things cause thyroid cancer. It's like, holy cow, why would anybody take these medicines? The reason they had to put that there is because they saw it in rodents, rats. Now, that doesn't mean like, oh, I guess it's not going to happen in humans. The difference is they have a different anatomy and biology. The rodents actually have those GLP-1 receptors on these specific types of cell. It's a specific rare type of thyroid cancer. It comes from specific cells called the C cells of the thyroid. Don't have to understand it that well, but humans don't have those receptors on their C cells. And if they do, they're not readily available. We haven't seen the signal in humans. Some mixed studies, observational trials, but from the most part, we don't think it's a concern, but we're monitoring. Blindness, if it does happen, it's extremely, extremely rare. You may have seen some of this recently in the past month or so, but the gist is these medicines can lower your blood pressure quite precipitously if you're losing a lot of weight. And so what happens is if you're not getting enough blood to your eye, some of the components in your eye, potentially can cause problems there. But again, very rare. And you just got to monitor blood pressure and stuff like that. Again, out of your scope, but if people are feeling dizzy when they're standing up, they may need to get their blood pressure checked and adjust their blood pressure medicines. I think it's all within your scope if people are feeling dizzy when standing up and working out, like have them talk to their doctor about their blood pressure. So the muscle loss, this is the big one that everybody's talking about. Let's see. I'm going to get into the muscle loss, because this is where I think you all are going to be very, very important. So there's pushback. I see it all the time online. I think a lot of people feel like, oh, these things are going to take our jobs, so let's try to fearmonger them. Obviously, you all are here to learn, but this is just kind of my perception. And you see a lot of doctors pushing back too. I think a lot of the kind of the lifestyle doctors are like, these things are bad drugs, but like, I think the future, honestly, I think a lot of people are going to be on these things, whether we like it or not. They need to be studied more for a bigger adoption in people that don't have the obesity, as I was talking about before, and those who don't have type 2 diabetes. There's probably people microdosing it right now. Actually, there's a lot of people doing that for reasons beyond weight. So I don't think they're going anywhere. All the studies seem to be pushing towards probably reductions in strokes and heart attacks and kidney disease and all sorts of stuff. And I think you all are going to be extremely important, and I'll get into this in just a second. But the gist is, these drugs facilitate behavior change. They're going to make your jobs easier. Let me go into why. As of right now, so these drugs help you eat fewer calories. They also help people. Now, do they automatically make people eat a broccoli instead of French fries or something like that, or whatever? I don't know. That needs to be studied. But in my experience, at least if you nudge people the right way, people now feel like they have the ability to do all the things that they know they should do, but just can't do because of that kind of brain pushing them to want to eat XYZ. Or it could be healthy, super healthy whole foods, but they want an extra serving of it. So the drugs basically cut that out, and now all of a sudden they're like, I can do this. But it's not only that. People now feel better, like they feel like they can exercise. They're in so much pain. There's an anti-inflammatory component to the medicine. It's not just the weight loss. There's something about the medicine that makes people go, oh my God, my joint pain's feeling good. Now all of a sudden they feel like, all right, it's time that I feel like I can exercise. Now the thing is, right now there's no, unless you count like anabolic steroids or something like that, which I wouldn't, because it's not a medical therapy, unless you have hypogonadism or something like that, low testosterone. There's no like exercise injection. And even still, the anabolic steroids, to make your muscles actually functionally useful, you do actually have to use them. So like, the job of trying to get people to eat fewer calories is now just made easier. The job to help get people eating a dietary pattern conducive to weight loss and improving their health just got easier. The barriers are lowered. But there's no drug that exercises people. They're trying to look into like myostatin inhibitors to make sure people don't lose lean body mass or lean fat-free tissue and muscle. But like, even still, some of those trials that have been coming out, they show that muscle's not necessarily functional. Literally, there's no exercise in a bottle right now. As of right now, maybe in the future, I can't say there's never going to be. But right now, this is where I think you all come in. So there was a big scare. It was like a year or two ago. There was a doctor that went on a news show that basically said 2/3 of my patients' body weight was lost to muscle, and now they're getting fatter because of these drugs. Well, that's not true. They've had studies, and that was just an anecdote. However, one of the semaglutide, the Wegovy, it did show a slight increase in what's called fat-free mass loss with the semaglutide in that step 1 trial when they looked at the subset of that population. It's kind of weird. We would expect more around like the 25 or so %. Again, this is fat-free mass loss. That doesn't mean it's actually muscle. Some of it could just be fluid shifts, because fluid on a DEXA scan in your muscle, if it's gone, it looks like you lost muscle or fat-free mass. So it's hard to know if that's actually muscle. But there was a slight signal with the semaglutide. Tirzepatide, however, showed more around that 25%. So tirzepatide, just a reminder, was the more powerful drug, that drug that got more, that 20% total body weight loss, whereas the semaglutide was only around 15. So that's around 25. That's kind of what we'd expect. But I want to show you all a quick little case study. We're we're publishing this with a few other patients, where right now we're doing a study on 100 patients and monitoring them. You can see right here in this graph, like this is totally one of your clients, basically. Like, they did everything right. They were eating optimal amounts of protein. They were lifting heavy. They didn't lose any lean tissue. This is what I see commonly in my clinic. And the thing is too, just to put into perspective, my patients, they come in going like, I want to hit a certain amount of weight because that's what my insurance said, my doctor said one day 20 years ago what my ideal body weight. There is no ideal body weight. It's all just that's nothing. There's no ideal body weight, but people want to look better. And there's nothing that makes people look better than obviously losing body fat, but also building muscle and shaping their body. It just doesn't happen. So I really think, this is why I think you all are going to be, I have like my own strength training programs, but you all are like literally specialize in this and do this every day. I think you're going to love what you see with your clients taking these medicines. It just completely makes your lives easier. So yeah, the resistance training, by far the number one thing. Some people will be like, oh, focus on the focus on the protein, and then if you can resist. No, the protein just is not even close to the effect of resistance training. It's just not even close. So you guys all have that going for you. I do want to get into some of this empathy and understanding, because I get so many patients that just don't even feel comfortable talking to their trainers, because they're worried about the shame, because they see it all this stuff online. But like, if you go like, great, if you kind of embrace them and be like, awesome, let's just help you be the best version of you and get you stronger and working on your fitness, and let the medicine kind of do its thing while helping them with their nutrition. I think you're going to just love seeing, I'm sure some of you all, if I did a poll, have seen some results with your clients and been like, wow, this is nice. So first and foremost, how to kind of communicate empathy, like just understanding where they come from. It's very hard. It took me forever. In medical school, I was kind of like, well, what the hell? Like, you just like actually got to try. Like, what are you doing? And it wasn't until like I started going to conferences, learning from other mentors, other obesity doctors. I started learning about the biology. It wasn't until I actually talked to people, though, as a budding physician. This was like 10 years ago, and been like, oh, okay, yeah, I guess they're all kind of saying the same thing. Like, it's hard, and it's not because they're lazy. It's because their body is driving them in a certain direction. I grew up in a very athletic family, very lean family. I always joke that my brother had abs in utero. We like, I can tell my body wants me to be thinner. I have to eat more to even hold on to my body weight right now. Whereas these other people, they're trying. They're CEOs, they're lawyers, they're doctors. They're trying very hard. And what they describe is just this inability to stop themselves from eating. So understanding that, very important, and kind of saying these medicines will basically help you feel the way that someone should feel who doesn't struggle with their weight. And the other thing is, it took me forever. So like, it's hard to do this in this little webinar to understand the obesity. But if the more clients you get, just listen to them talk, ask them to explain it. Again, staying within your scope, but like thinking about these medicines as tools to facilitate the behavior change as opposed to an easy way out. If anything that you get from this is that, you're already ahead of everybody else when it comes to this. I think you're gonna, I think that's kind of the key. So like, the understand. So like, you got someone in front of you. You got a client who maybe they have knee pain, maybe they're struggling and whatever else with some of the exercises. Obviously, you all are going to be experts at finding exercises that are less painful and whatever, but just kind of seeing what their life is like. The stress, there's also a lot of stress from thinking about food and the stigma of obesity that makes people feel so ashamed that it takes a toll on them. So if you just understanding the medicine just takes that biological driver. It doesn't always, by the way, there are some people that don't respond to the medicine. So that's a whole nother thing, because like, if you assume like, well, what the heck, this person's on this medicine, it's not working. Some people don't respond to it. I showed you that categorical weight loss. Some people don't actually respond to it, and it does happen. Some of the newer drugs coming out, it just melts fat off of people. There's one called the retatrutide, and some of these other ones that's like pretty much everybody responds to the medicine. But for the time being, again, just understanding where they're coming from, that empathy. Just want to see, I want to make sure I didn't miss any quick questions. So Christy asked, in regards to the risk of the thyroid cancer, how long would someone have to use it before being in a, so like there's no known increased risk. If they have a family history of that specific type of medullary thyroid cancer, we don't prescribe it. We can do genetic tests to see if they're at risk. But as of right now, there doesn't seem to be an increased risk from using it. Shelly asked, what about those that are within the healthy weight range but struggle with food noise? They're thinking about food, subsequent disordered eating at last-ditch effort, similar to adding an antidepressant for someone who's still struggling. I have played around with that. It's just not indicated, so insurance wouldn't pay for it. So they'd still have to talk with their doctor. It'd probably be on the lower doses. Again, not indicated from an FDA labeling standpoint. There may be some doctors that play around with small doses there. Not out of the question. It's just not standard of care right now. Ridwan, since weight gain is a symptom of a bigger issue, do you suggest we rather focus on the main issue of all these problems, metabolic disorders, weight gain, since practically all medications suppress the symptomatic effects? Yeah, it's more so like, so if you think about people, why do people gain so much weight recently? Our biologies didn't change all of a sudden to where, and our genetics didn't change to where, oh, now we're gaining weight. Our environment changed, but our genetics within this environment sets us up for a disaster. And once people gain the weight, the biology does change where there's inflammatory effects in the brain to where then when they try to lose weight, the body fights them hard. So that's where the medicine comes in and then goes, oh, the body's not going to fight them as hard. So I would just focus on the things that you can with these patients, their clients that are taking these medicines, the movement and the food. Kendall, how do these GLP-1s interact with chemicals like MSG in processed foods designed to override? So yeah, these medicines should hit the receptors in a way to where, I kind of talk, like I make the analogy like in the Matrix, where Neo's talking to Morpheus. If anybody remembers that movie, but basically Neo's like, what are you saying? When I'm ready, I can dodge bullets. And Morpheus is like, no, when you're ready, I'm saying you won't have to. Like it allows people just look at those foods and not even have to have them. It's amazing how well they work in terms of that. Lucas, are you saying the receptors affect the brain and we don't know how it works, but it doesn't really matter? No, so we know they affect certain receptors in the brain, but there's probably other things there that they're trying to do all sorts of PET scans, functional MRIs, and it's really interesting how they do these things where they have to radio label these things and see where they go in rodents and then see if that kind of works out in humans. Anyway, Allie, any risk of malnutrition deficiencies? Yeah, so similar to surgery. So diarrhea, usually self-limited. You do want to make sure people are hydrated with electrolytes. Like if people are having diarrhea, and you obviously send them to their doctor, but the biggest thing is making sure people are hydrated. Like what we don't want is people to get dehydrated. And when you get dehydrated so much, you don't have enough blood getting to your kidneys, and that can hurt your kidneys. Now the drugs overall protect your kidneys, but if you're acutely dehydrated from dehydration, that can injure your kidneys. Yeah. Shelly, what effects on mood? Yeah. So in general, when people have a lot of anxiety in general, thinking about food and whatever else, these medicines seem to have like this anxiolytic, they decrease anxiety a little bit. However, some people notice an increase in anxiety, happens once in a while. And then sometimes these these medicines work on the dopamine in the brain, the reward centers in the brain, and dampen it down. So like, they're kind of like that. I don't want to say food addiction, but addictive likeness a little bit. But we're noticing people may drink less alcohol. They're gambling less. They're not biting their fingers as much. So there's likely an effect there. But sometimes they dampen it too much. And that's where we notice people kind of, it's called anhedonia. It's the meh, take it or leave it. I don't know. So I just had a patient the other day. It's just a cool story. They were on 15 milligrams of the tirzepatide, the Zepbound. And in January, I remember they were like, I've been plateaued here for months. And I was like, well, I think we should decrease the dose. So I decreased the dose because they were just kind of the way they described it. I'm like, I'm not going to the gym anymore. I don't feel like going out and walking. Decrease the dose. And then all of a sudden they started losing weight again. I didn't see them until 3 months later. And they're like, oh my God, I've lost 10 pounds. I'm back in the gym. I'm feeling good. So because I think the medicine was just dampening down their drive. It was kind of, so stuff to be aware of that. And that plays into, is it fatigue, like feeling tired, or are they just kind of like lack of motivation, something to have, refer them back to the doctor about. But I do see that. Okay, let's see if I can get a few more slides here before we, I do want to mention these medicines aren't fat burners. It's still about energy balance. There's people that claim that they're not about energy balance. They help people improve their energy balance, plain and simple. Now they've tried to do more and more studies to understand this a little bit more, but it's energy. It's still energy balance. And this goes into what I was saying before. There's an appetite dysregulation that occurs once people develop obesity. And this appetite dysregulation is what makes it very difficult for people to stick to some sort of program. Like people are like, well, why don't they just stick to it? Yeah, I know they should just stick to the program. That's what they keep trying to do, but they seem to not be able to do that. And these drugs basically go and rewire the short circuits that are occurring in the brain that are causing the appetite dysregulation. It just facilitates it. So going to your scope, and then I'll get into more of these questions here a little bit. The medicines facilitate the change, but they don't make people work out. That's where you come in. The medicines will make your job so much easier in terms of helping people work out. And like, I've just seen amazing effects from when, of course I have my own little workout programs, but like the best effects is when they have a one-on-one strength coach or fitness professional personal trainer helping them out and really individualizing their care. And my patients tell me, like, when their personal trainers are like all for the meds and like really empathetic about it and understanding, they just love their trainer so well. And then your scope in terms of side effects, I mean, like fatigue, again, I think this is where you could come in and go like, make sure you talk to your doctor. You're not feeling right, or you don't feel like coming in. That's not like you, Joe or Sue or whoever they are. Something to kind of keep an eye on their intensity and volume and how they're doing. They do make people eat a lot fewer calories. So sometimes it's not the drug causing the fatigue, which it is in a lot of cases, but in other cases, they're just not eating enough. So you'll notice that when they're just not able to do the amount of volume and they're struggling in the gym. I think it's within your scope to at least tell them, like, hey, talk to your doctor about the dose. Maybe you need to adjust it. Nausea, just be aware. If people are like coming in trying to work out and they're not feeling well, obviously. And then, obviously the diarrhea and the reflux and those things. But those are the common things I think are reasonable to chat with them about. Well, we wanted to get into sales, but honestly, like if you're able to like understand these medicine, people don't want to work with someone that's going to wag their finger or shame them, obviously, but there's also kind of a implicit bias or it's kind of these subconscious biases. If you can work on trying to like embrace them and be like understanding, like, cool, you're going to do great with these medicines and I'm going to help you there. I've had tens of thousands of patients I've overseen in various programs that I've been at, and personally thousands of patients. And they say kind of the same thing. They had to leave a trainer because the trainer was poo-pooing the drugs and saying you shouldn't be using these Band-Aids or crutches or shortcuts. I'm telling you, these they're going to make your life so much easier. And so, like, showing the clients that you're there for them regardless of whether they take medicines or not, and you're going to help them through it, and you know about the medicines and understand them, they're going to love you. Now, I'm going to try to get into more of these questions here. Let's see. Gilberto, are there foods or frequency of eating that works better or worse when on these medicines? Yeah, in general, if they're feeling nausea, smaller meals, lighter meals, more frequent seem to be better. Bigger, larger, heavier meals less often tends to cause more of that nausea. Again, it's, got to be careful about the scope there, not going into medical nutrition therapy, but like, it's I think that stuff is like a kind of common sense to help your clients. Sorry I had to go, Ridwan. I was like, shoot, I'm reading all this thing. Yeah, so the bone density, Alicio. So bone density, I've posted about this before. Bone density doesn't seem to be an issue on these medicines if you have obesity. Now, if you are lean and going from like you're already lean to going to really lean and getting like underweight, potentially a bone density problem. But resistance training, especially those with obesity, minimizes bone loss with weight reduction.
Just a quick question. Before, I'm going to cut in, but before you mentioned that story about how you reduced the dosage for that person, then their motivation kind of went up and they started losing weight again, things like that. Is that process of continually checking in with a doctor something that all people on GLP-1s will get, even if they go through insurance and all sorts of things, or is that more something specific to like you and your clinic that you do?
So the usual model is in insurance. So I'm just straight up, I call it direct care. Mine's $150 a month. You can text me whenever, you can check in whenever, but I have, no matter what, like monthly check-ins, at least via a form that I have to read, but they can do videos if they want. But the normal model is like insurance. They get like a 5-minute appointment, and sometimes they can't get in for a few months at a time. So it's hit or miss. I think more touch points is better, especially in the beginning phase. Once you're on maintenance on these medicines, it's kind of like, all right, what am I going to do? Like, they're just on this drug indefinitely and they have no issues. But during the titration phase and like a little bit further, and if they're having troubles, like, you want more touch points to go, like mood. Are you losing too much weight too quickly, or not losing enough? Are you having side effects? So more touch points, more communication is better, ideally. Mm-hmm. Bailey asked, how do you ensure they're getting enough, are still meeting their nutrition needs? Yeah, so that's an issue. That's why we're like, hey, we got to check in. Is your appetite, like, some of these patients come in going like, nope, I don't want any appetite. I don't want to be able to eat anything. It's like, well, that's not good. You got to eat. So that's part of it, is making sure, like, is your appetite too suppressed? Or are you feeling so nauseous? So in some, a lot of people, we do make sure they're taking a multivitamin. We got to make sure they are taking a protein shakes. Ideally, they're eating whole foods, but it can be really hard. Like, a lot of my protein comes from protein shakes, simply because, like, I don't feel like eating a huge, sirloin or chicken, salmon, whatever, all the time. So, like, sometimes we have to, we monitor it closely.
I highlighted one. It wasn't necessarily a question, but just more of a statement from Harvey, but I just thought it really sort of nailed it. And he just said, for everyone listening, that what he's observed is that clients on the meds can successfully maintain lean muscle mass if they know what to do, right? So again, kind of putting it back to us as health and fitness professionals is like empowering them with the tools and the knowledge to do it properly, right? So I just thought that, Harvey, if you're still in the chat, amazing thing to drop in there. 100% nailed it. So just wanted to put that one in there.
Yeah, no, like the thing is, nobody else is going to be able to do the resistance training for it. That's the only thing we have right now that is a major, I mean, again, we have protein, but like it's resistance training, and it's going to make them look the way they want to look. They don't know that a lower weight isn't necessarily what they're going for. They're going for a look, and they don't, the patients or your clients don't even understand it really.
Yeah, I think that's a really good flow into the next question too from Benicia, but just when you sort of referred to optimal resistance training, what does that look like in terms of, you know, maybe frequency, duration?
Yeah, we, you know, I try to shoot for ideally at least 2 days a week of full body. Now, if we're going more optimally, we're looking at like 3 or 4 days, but like it's hard. People, it's hard to get. So like at a minimum, we're trying for 2. At the bare minimum, 1 day a week of full body. But like if we're splitting, you know, trying to split hairs and make it practical, 2 days. If we want it a little bit more optimal, 3, maybe 4 days. But I think that if they're like minimal effective dose, we're looking at probably 2 days full body resistance training, and we're looking at like within that 2, let's see, 2 sets for each muscle group in each session, getting, you know, a rep or 2 away from failure. And people, the thing is, a lot of these patients don't know anything about what failure even feels like. I've gone and lifted with them, and they're like, "Oh, the hell!" And they're just sitting there talking to me, and then they'll finish their set. I'm like, "Man, that's not."
Yeah.
No, you gotta. We're gonna have to boost those numbers. Those are rookie numbers. We got to bump those numbers up.
Yeah. I'd say too, like, and correct me if I'm wrong here, but probably one of the things, just like with any client that's probably coming to you that's, you know, got an obesity problem and likely hasn't worked out ever or in an extremely long time, like you don't have to go from 0 to optimal, right? Like I would imagine, like if you can get them 2 minutes, sorry, 2 minutes, 20 minutes twice a week to begin with, and then slowly build up over time. Like it's not just like 0 to 100 straight away. Just like with a lot of clients that aren't on the drugs, it's the same sort of process, right?
That's exactly right. I mean, some of my patients, I just start walking, and then I'm like, all right, can we get maybe 1 day a week? And you start, you know, figuring out these exercises. And then once they start feeling good, they lose a little bit of weight from the medicine. The joints are starting to feel better. Like, ooh, I like the way this feels. And then some of these people get obsessed with it. I'm like, holy cow, you're lifting more than I am. Like, what the heck? It's amazing. It's cool.
Yeah.
Oh, Nicole, the time frame. So these medicines are meant to be used indefinitely, chronically. Now, having said that, not everybody has to use them that way. It's similar to like a blood pressure medicine. So like, let's say the blood pressure is 150 over 90 or something. You want to get it down to 120 over 80. You give them, and they're doing all the lifestyle stuff, and you give them some time to try to do it, and they just can't get it down. You give them a blood pressure medicine, all of a sudden it gets down to that 120 over 80. So now we normalize their blood pressure. It'd be like taking away their blood pressure medicine, and then you see it go back up. So these medicines, they dampen that drive to want to eat. When you remove them, that drive to want to eat comes back. But there are around 10 to 15, maybe 20% of people are able to come off of them and seem to hold their weight off after about a year. So, but I think a lot of people are going to at least need to be on a low dose of something, at least like, and spread it out. It doesn't have to be weekly. And then some people go on and then come off for a few months and then go back on. Kind of interesting how people are playing around with it.